Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 32nd episode of Optometry series. First of all, I'd like to thank each and every one of you for their continuous support towards Optometry series. The topic for today is Retina Speaks. I'm very happy to welcome our today's moderator, Ms. Mahalakshmi, ma'am. Thank you so much for joining with us today, ma'am.
Hi.
Thank you, ma'am. Thank you so much, ma'am, for coming.
Thank you.
I would like to welcome my team members, Ms. Anshika, ma'am, and Ms. Meenakshi. Thank you so much, both of you, for your continuous support. Yes. So we are with us today's MC, Ms. Janapriya. Janapriya, please introduce today's moderator, Kanna.
Okay, ma'am. Good evening, everyone. I'm Ms. Janapriya, a second-year bachelor student in optometry at Dr. Agarwal's Institute of Optometry. I'm very happy to welcome our moderator for today is Ms. Mahalakshmi, ma'am. Mahalakshmi, ma'am, completed our BS in optometry at Elite School of Optometry. She is a senior optometrist who has been working in the retina department at Shankar Nethralaya, Chennai. Past years with 11 years of experience. Thank you so much, ma'am, for joining us today. The presenter for today is Ms. Punitha, a technical member of the Optometry series and the third-year bachelor student in Optometry at Dr. Agarwal's Institute of Optometry. Ms. Punitha, please start your presentation.
Thank you, Ms. Janapriya. Okay, good afternoon. I'm Ms. Punitha Estate, third year student from Dr. Agarwal Institute of Optometry. And today's topic is about retina, so Retina Speaks. So we can start with a small intro about retina. Yeah, ma'am.
Your screen is not visible.
Okay, just start with a small intro about retina. So we all know that it is a innermost tunic of the eyeball. It's a thin, delicate, and transparent membrane. It extends from the opticus to the ora serrata. If you look for a thickness, in peripapillary region, it will be approximately 0.5 mm, and at the equator, it will be 0.18 to 0.2 mm, and at the ora serrata, it will be approximately 0.1 mm. And the color of the retina will be purplish red because of the presence of rhodopsin. Okay, next look for the regions. We have opticus, macula, and the peripheral retina. Then the microscopic structure of the retina, it consists of 10 layers with two distinct functional components, one with RPE, that is pigment epithelium, and the sensory retina. And these 10 layers from outward to inward, starting from RPE, retinal pigment epithelium, followed by layers of rods and cones, external limiting membrane, outer nuclear layer, outer molecular or plexiform layer, inner nuclear layer, inner molecular or plexiform layer, ganglion cell layer, nerve fiber layer, and internal limiting membrane. And this is an OCT picture of the normal layers of the retina. This is a just pictorial representation of the retinal layers. Then followed by the blood supply. If you look for a blood supply, the outer four layers, that is from RPE to the outer nuclear layer, it is from anterior and posterior serial artery, and the inner six layers, that is from outer plexiform layer to the inner limiting membrane, it is from the central retinal artery. Then we can move on to the retinal stines. If you look for retinal stines, there are n number of retinal stines. We can start with deposition and just move on one by one. So first one is deposition. Depositions like we can say exudates, cottonwood spots, flecks, and so on. So starting with drusen's. If you look for drusen's, what is drusen? These are the yellow focal deposits that are located between the basal lamina of the RPE and the inner collagenous layer of the Bruch membrane. And these are made up of lipids and protein. And this is the classic sign of ARMD, that is age-related macular degeneration. This is quite visible in the RPE layer. And the drusen's can be of different sizes, ranging from small, medium, and large. If you look for other drusen's, which can be found in the optic nerve, and that does not affect vision. Then flecks. So flecks are the numerous yellow-white round, oval, or pisiform lesions we can see at the level of RPE. And these are confined at the posterior pole and may extend to the mid-periphery. And new lesions will develop as the older ones will become ill-defined and atrophic. And this is a sign of Stargardt disease. And these are some OCT pictures, and arrow marks are pointing the flecks. Then exudates. So coming to exudates, these are lipid and lipoprotein deposits that appear near leaking capillaries within the retina. And these are composed of lipoprotein and lipid-filled macrophages, which are being seen in the outer plexiform layer. And this can develop at the early stage of diabetic retinopathy. So the hard exudates are quite visible with this OCT picture. Then succinate rings. These are exudates which are arranged themselves in a circular pattern, and in the center of this ring pattern, we can able to see cluster of leaking microaneurysms. Then cottonwood spots. So these are also known as soft exudates, and they are elevated, small, yellow-white or gray-white cloud-like, linear or serpentine lesions with fimbrigated borders. And these will be a result from the ischemic disruption of nerve axon, the swollen ends known as cystoid bodies, and these are quite visible in the nerve fiber layer as globular structures. And diabetes mellitus and systemic hypertension are the most common etiology. Then we can easily notice the differentiation of the cottonwood spot, exudate, and drusen's, starting with drusen's that can be quite visible with the RPE layer, and exudates from the outer limiting membrane. Next, so cottonwood spots can be seen in the nerve fiber layers. Then edema. So CSCR, that is central serous chorioretinopathy, and this is nothing but the spontaneous serous detachment of the neurosensory retina, which will be seen in the macular region with or without the RPE detachment. Then followed by central macular edema. This is also a collection of fluid which can be seen in the outer plexiform and the inner nuclear layer with center around the foveola, and this will show the loss of foveal depression with cystoid spaces and overall retinal thickening. Then we can see about the serous or serous or hemorrhagic PED, which is nothing but pigment epithelial detachment. And it is a condition where the fluid or the blood gets accumulate under the layer of the RPE, and it causes a dome-shaped elevation, as is shown in the OCT picture at the top, with short borders. Then comes the Vogt-Koyanagi-Harada syndrome. It is an idiopathic multisystem disorder. This will include cutaneous, neurological, and the ocular lesions. And this is a posterior uveitis lesion that includes the multifocal choroiditis, and that will lead to the exudative retinal detachment and the choroidal depigmentation, which will represent the retina with a sunset glow fundus. And this is a picture representation. The D represents the OCT image, and it's a quite diagrammatic representation of the VKS syndrome. Then comes the hemorrhages. So if you look for a hemorrhage, first starting with vitreous hemorrhage. So these hemorrhages will be like diffuse patches of blood, and this will obscure the retinal vessels. Then pre-retinal, that is called subhyaloid hemorrhage. This will occupy usually a group of 3 to 8, and dark center with glisten light reflects frayed edges. And coming to deep intraretinal hemorrhages, this will be dot and block hemorrhages. Then coming to subretinal, and this will present between the photoreceptor layers and the RPE layer, and the red blotches with round lobligated borders beneath elevated retina, and they will usually extend. So then coming to pre-retinal hemorrhage, these are typically round. Then after over time, it becomes a boat shape, and this will also obsess the retinal vessels. Then coming to superficial intraretinal hemorrhages, and these are called flame-shaped hemorrhages as they are elongated with the frayed borders. Then the retinoschisis. So it is a schisis cavity that is surrounded by the hyperpigmented or hemorrhagic arc or an elevated retinal fold. Then the subretinal pigment epithelium, that is choroidal hemorrhage, that is dark slate color with a smooth border surrounded by the red ring. So, as we talk about vitreous hemorrhage, this will be a common condition in many cases, like if there is any underlying retinal tear or detachment, or in retinopathies, or in retinal vascular disorders, and etc. And these are some pictures. We can able to see dot and block hemorrhages, boat shape hemorrhages, and flame shape hemorrhages. And these are the other vascular changes. We can able to see IRMA, intraretinal microvascular abnormalities, venous bleeding. This is an OCT picture of, sorry, FFA picture of venous bleeding and silver wiring. And these are some classical signs of hypertensive retinopathy. And we can able to see the AV nicking. Then comes this. If you look for the central retinal arterial occlusion, we can see attenuated blood vessels. There is narrowing of blood vessels, and cherry red spot is the classic hallmark sign of CRAO and with pale retina. Then comes the CRVO with the bifurcation. The occlusions can be seen in the area of bifurcations. And CRVO, this will indicate the tomato splash appearance, followed by BRVO. Then the choroidal neovascularization, and this is the spectrum of exudative ARMD. This will consist of the abnormal growth of vessels from the choroidal vasculature to the neurosensory retina through the Buch membrane. If there is any leakage of retinal hemorrhage or retinal edema from the C and V, this will threaten the vision. If you look for the etiology, it is a multifactorial. Either it can be an alteration in Buch membrane, or the migration of macrophages, or the production of VEGF, that is vascular endothelial growth factor. Then these are some ICGA pictorial of C and V. We can, in picture A, we can able to see like blood and fluid at the macula, which are surrounded by the hard exudates, and B, C, and D shows the hyperfluorescence underlying the C and V. Then next one is breaks or tears. Starting with horseshoe tear, these are also known as flap or U-shaped tears with a full thickness breaks in the neurosensory retina that can occur secondary to vitreoretinal traction. If you look for the apex of the flap, that can be pulled anteriorly into the vitreous cavity, while the base will just remain attached to the retina. And these flaps are found between the ora serrata and equator because it is a thinner region of retina when compared with the posterior region. And horseshoe retinal tears will be a leading cause of fragmentogenous retinal detachment. And these are the pictures of horseshoe tear. Then comes the retinal breaks and holes. So retinal breaks will get developed in most cases with the result of traction at the site of vitreoretinal adduction, and it can also occur in patients with 1 in 5 eyes with symptomatic DVT. While if you compare with retinal holes, this will develop due to the progressive thinning of the retina. Then a patient with the acute retinal tear, they will experience the floaters. Then coming to retinal dialysis, it is a circumferential retinal break that are located at the ora serrata, and this is the common cause of retinal detachment in children and young adults. So unlike a retinal tear, if you look for a retinal dialysis, the retina remains attached to the vitreous base by its posterior edge. And these are the pictures. From A, is quite visible, the dialysis of the retinal with retinal attachment, and B shows the avulsed vitreous base. This is the equatorial retinal breaks followed by the traumatic macular hole. Then we can able to see the round holes. If you look for the white arrows, this shows the atrophic holes, while the black arrow shows the hole with the localized subretinal fluid. Then D shows the retinal dialysis, while E shows the giant retinal tear. Then comes to retinal detachment. If you look for retinal detachment, it is of three forms: rhegmatogenous RD, tractional RD, and exudative RD. So coming to rhegmatogenous RD, so this RD will be having some retinal break with concern with the vitreoretinal traction, and this also allows the accumulation of liquefied vitreous under the neurosensory retina that separate the neurosensory retina from the RPE. If you look for tractional RD, it occurs because of tractions like can be seen in proliferative retinopathy such as carpet retinopathy, retinopathy of prematurity, and penetrating posterior segment trauma. And exudative RD, and this will be characterized with the accumulation of subretinal fluid in the absence of the retinal break or the traction. And this can also occur in variety of vascular, inflammatory, and neoplastic diseases involving the retina, RPE, and choroid, in which fluid leaks outside the vessels and accumulates under the retina. Retinoschisis. By the name, schisis means it is a split or a cleft. So the term retinoschisis refers to the splitting of the sensory retina into two layers at the level of inner nuclear and outer plexiform layers. Then this can occur in two forms, congenital or acquired. If it is occur at the middle age or beyond, it is known as senile retinoschisis. And these are the pictures. We can able to see the inner and outer retinal breaks. And this is an OCT image of a retinoschisis. And these are the large outer layer breaks. And here is another OCT with the inner retinal schisis and the outer schisis. Then comes the lacunar cracks. These are the breaks in Bruch membrane, and it is seen in high myopic eyes. Then PVD, so posterior vitreous detachment. So this is a detachment, that is separation of posterior vitreous cortex and the internal limiting membrane of the retina. So it is visible like vitreous cortex getting detached from the inner limiting membrane. Then the pigmentations. So bone spicules. So if we come to bone specule pigmentation, these will represent migration of pigment into the interstitial spaces of the retina from this integration of the RPE cells. So when there is any direct contact between the inner retinal vessels and the RPE, this will triggers the migration of the RPE cells. And bone spicules are made up of RPE cells, cell pigment, and reflect the capillary network at the time of formation. This is a classical sign of RP, retinitis pigmentosa, which is nothing but rod cone dystrophy. The cone will get degenerative, or it becomes affected at the starting stage, followed by the cones, so-called rod cone dystrophy. Then these are some progression of retinitis pigmentosa. The A and B represents the early stage where a small amount of RP pigments can be seen, followed by C, that is, this is the advanced stages where some retina remains, and this is the end stage where the RPE pigments are being accumulated in many areas. Then comes the labor congenital amaurosis, and this is a severe rod cone dystrophy, autosomal recessive, and it is a commonest genetically defined cause of visual impairment in children. So if you look for the initial stage, a mild periphery pigmented changes can be seen with salt and pepper changes with yellow flakes, and in the severe stage, we can notice the macular pigmentation or the coloboma-like atrophy. Then in later stages, we can see with pigmentary retinopathy, optic atrophy, and severe arterial narrowing get manifested. And these are the pictures. So the A represents the mild pigmentary retinopathy, and B represents the macular pigmentation with optic disc drusen, then followed by coloboma-like macular atrophy. And this is ocular digital syndrome, where the child's like poking the eyes with the knowledge. Then it comes the bullseye appearance. So this is the bullseye maculopathy. It's a classically described, but it is not a universal. Then the macula shows the non-specific central pigment changes or atrophy at the site of RPE. A sign of cone dystrophy can also appear in the Stargardt disease at beaten bronze paramacular appearance. Then comes the vitelliform lesions. And these are the round, sharp, delineated macular lesions that have a size between a half a disc and 2 disc diameter. Size develops within the RPE. This is a classical sign of vitelliform macular dystrophy, and this occurs in infancy or early childhood, and it does not usually impair vision. Then gyrate atrophy. So this is caused by the mutation of gene encoding the main ornithine degradation enzyme and ornithine aminotransferase. When there is any enzyme deficiency, this will lead to the elevated ornithine levels in the plasma, urine, cerebrospinal fluid, and the aqueous humor. If you look for a signs, the mid-peripheral depigmented spots are associated with the diffuse primary mottling may be seen in asymptomatic cases, and sharply demarcated circular or oval areas of chorioretinal atrophy develop. These may be associated with the numerous glistering crystals at the posterior pole. And these are some pictures. This is the early stage of gyrate atrophy, where we can see only a few amount of peripheries get affected, while the advance has been huge. Then comes the beard tract. So CHRPE, congenital hypertrophy of the retinal pigment epithelial lesions. These are typically flat, well-demarcated, hyperpigmented lesions of the retina. And these can occasionally seen in a group configuration that resembles the footprint of an animal or a beard tract. So these are located in the peripheral, but not occasionally in the peripapillar region, and known to be associated with systemic findings such as familial adenomatous polyposis and Gardner syndrome. And this is a picture of the gyrate atrophy. We can able to see a group of footprints have been seen as a beard tract. Then comes the snail track and lattice degeneration of the retina. So these are the two common fractional degenerative lesions that result in retinal breaks and distant lesions. If you look for this snail track, this will have a appearance like a snowflake that gives the peripheral retina a white frost-like appearance. And this will be viewed in some as a precursor to the lattice degeneration. Coming to lattice degeneration, so this is commonly a bilateral, temporal, and superior. This is a spindle-shaped areas of retinal thinning, and they are located between the equator and the posterior border of the vitreous space. And a sclerosed vessel forming a herborizing network of the white lines. And some lesions may be associated with snowflakes, remnants of degenerate Muller cells, and are associated hyperplasia of the RPE is common. And these are the pictures, while the first one shows the multiple lesion with the small holes, and B shows the scleroid vessels that with the white network, and a vortex vein is seen supernasally, while this shows the retinal detachment with lattice on the flap of the tear. Then comes the choroidal nevi. Choroidal nevus that will be typically a dark pigmented lesion. So this will similar to freckle or a mole found on the skin, and these are arises from the pigment containing cells in the choroid. So when there is any this nevus causes degenerative or dysfunction of the overlying RPE, a fluid may accumulate under the retina, or there will be any abnormal blood vessels may develop and bleed or leak. Then comes the choroidal melanoma. So as this is a rare malignant tumor, but it's the most common primary intraocular neoplasm, and it ranks the second most top of 10 most malignant melanoma sites in the body. So coming to the tumor composition, so this will be exclusively spindle cell or a mixture of the spindle and epithelioid. And these lesions may penetrate Bruch membrane and the RPE with herniation into the subretinal space, and classically assuming the shape of a collar stud. And scleral channel and vortex vein invasion can lead to orbital spread. And metastasis is commonly to the liver, bone, and lung. Only about 1 to 2% of the patients have detectable metastasis at the time of presentation. Then this is the picture. The A shows the typical pigmented melanoma, and B shows the amyelinated lesions, the absence of melanin. And C shows the melanoma of the optic disc, while the D shows the overlying orange pigments. And this shows the hemorrhage and exudation. Here's a hemorrhage and exudation, followed by F. This is a subretinal fluid with bullous detachment. And these are my references. Thank you.
Thank you, Punitha. Just a minute. Yeah, thank you so much, Punitha. And the essence of today's presentation is to understand there are similar signs in the clinical pictures of retina. So, based upon locating the site, it is very easy to differentiate the conditions. So, in that case, Punitha, it was a very wonderful presentation with all the classification listed as much as possible for the time limit. And now I request our moderator, Ms. Mahalakshmi ma'am, to share your inputs, ma'am.
Thank you. First, I would like to thank Anshika for giving me this opportunity and Ms. Janapriya for introducing me, and Ms. Punitha. It's a wonderful and a very informative presentation. First, actually, when they have put OCT image, I would like to tell OCT plays a major role in diagnosis, retinal diagnosis nowadays, and also for the treatment outcomes. And I would like to give some OCT aspects to share. I would like to share my OCT knowledges with you. Basically, OCT interpretation is done based on the reflectivity. That is hyper, hypo, and moderate reflectivity. Coming to the retinal layers, there are 10 layers of retina. In that, RPE, nerve fiber layer, and ellipsoid layer, and ILM. These are hyperreflective layers. And plexiform layers and external limiting membrane is moderate reflective. And nuclear layer will be low reflective. These are the basics. Okay. Coming to the presentation, it was a similar findings with different conditions, right? What are discussed are bruisins, exudates, flex, and cotton wool spot. In simple, bruisin will be a undulation of the RPE layer, that is just bumpiness. When you see a bumpy in the RPE, that will be, we can think of bruisins, and exudates, that will be present in the outer plexiform layer. And flex, there are two types of flex, that is type 1 and type 2. It is a small pyramidal structure. It will be like a small pyramidal structure that will be seen in RPE, that is type 1. If it goes to outer nuclear layer, then we call it as type 2. Then is cotton wool spot, which comes in nerve fiber layer. Bruisin, exudates, flex, cotton wool spot, these are hyperreflective lesions. Even though they are hyperreflective, based on the level they are present and the shapes, these can be differentiated. Next comes optic nerve head bruisin. Is it possible to go to that picture?
Yes, Punitha, can you share your slides, please? Yeah, can you just open the slide and show the picture that Mahalakshmi ma'am is asking for?
Just a minute, ma'am. I'll help her out.
Next. Before that. The before one, optic nerve head bruisin.
Yeah, yes.
Optic nerve head bruisin, this is a calcified nodule seen in optic disc. You can see a round hypospace with the uniform hyperreflective round borders. This we call it as optic nerve head bruisin. There will be a superficial and buried bruisins. Yes, superficial, the name tells it is present at the superficial layers, but buried bruisins, it is little difficult to find in OCTs. These bruisins can be well seen in OCT with help of EDI mode, that is enhanced depth mode. Other diagnostics to confirm ONH bruisins are ultrasound and autofluorescence. Next, edema and SRF. These are hyporeflective things. And SRF, it is a subretinal fluid, the fluid which is seen between ellipsoid layer and RPE. The ellipsoid layer, the space between ellipsoid layer and RPE, we call it as subretinal space. if the fluid is present in that, we call it as subretinal fluid. And edema, it is present above the ellipsoid layer. So, the key point you have to look for is ellipsoid layer. If the fluid is present below the ellipsoid layer, we call it as subretinal fluid. And if it is present above, we call it as edema. Next is PED. PED is the elevation of RPE. The discussed PEDs are serous and hemorrhagic. Serous will be a dome-shaped, and there will be a presence of Brooks membrane, and it is optically empty. It will be clear. And hemorrhagic PD, it is also dome-shaped, but there will be slight moderately reflective echoes will be seen underlying the RPE, and absence of Brooks membrane will be there. And another one type of PD is there, that is fibrovascular PD, which is irregular. It is a combination of fibrous and vascular. So in fibrous part, there will be a backscattering, and vascular part, there will be a shadowing. And you will see a Brooks membrane partly. The types of PD is also important which helps us, gives us clue in diagnosis. That is, if you see a serous PD, you should think for CSR. Hemorrhagic PD, we can think for IPCV, that is idiopathic polypoidal choroidal vasculopathy. And fibrovascular PD, we can think for CNVM. Next thing was discussed is VKH. In VKH, you saw a presence of subretinal fluid, and there is a subretinal fibrin, which is moderately reflective deposits. And there will be a choroidal thickening also is there, and choroidal folds. Yes, there is a higher version of OCTs like SWEP source will help us to view the choroidal lesions well. And after treatment also, for these uveitic lesions, after treatment also, how the thickening is reduced, how the fluid level is reduced, the reduction in activity also can be monitored. Next is hemorrhage. Hemorrhage, they have discussed subhyaloid hemorrhage, intraretinal hemorrhage, and subretinal hemorrhage. So pre-retinal hemorrhage, that is subhyaloid heme. How to look for is, you will see that posterior vitreous detachment. From that, you will see a hemorrhage that causes shadowing. Shadowing means underlying structures will not be seen. So in SHH, you have to look for that PVD line, and underlying it, you will have a hemorrhage. And sub-ILM, just below the ILM level. Intraretinal at the retinal layers, and subretinal heme, same like SRF, you will have a subretinal fluid. In that subretinal space, if you have a hyperreflective thing which causes shadowing, that will be a subretinal heme. So in that also, OCT helps us to tell us where the level of heme. And next discussed was occlusion, right? Occlusion, basically we have to check for the presence of fluid. Presence of edema, subretinal fluid has to be checked. In case of central retinal vein occlusion, there will be a diffuse heme. But in case of branched retinal vein occlusion, the heme will be present at the specific quadrant. Next discussed was CNVM. CNVM, we have to check for whether it is active lesion or scar lesion. Active lesion, basically CNVM, how in OCT, it will appear as a RPE disruption. RPE disruption, if it is the margins are fuzzy and the presence of subretinal fluid or subretinal heme, any cystic spaces, any and thickening, if it is there, then we call it as active. If the RPE layer border is well defined and it is very hyperreflective and there is no fluid, no thickening, then we call it a scarred lesion. Schisis, it is elongated lines, as she mentioned. How to differentiate cystic and schisis? With the help of that septate. If you see elongated lines, then it is a schisis. If it's little round, we call it a cystic. HMT, everything was discussed. In best, OCT pictures was mentioned. In that, you have to look for the ellipsoid layer thickening, which is a classic sign for Best disease. And then atrophy. Atrophy is basically, you will see increased reflectivity in the choriocapillary layers. That we call it as backscattering. And there will be a loss of photoreceptors. Then we call it as atrophy. Yes, she nicely explained on choroidal lesion, nevus, and melanoma. In the choroidal lesions, as I said, higher versions like SSOCT, we can measure the lesion size also. After treatment, how the lesion size is reduced, we can monitor that. And major thing is we have to check for the fluid presence. Thank you.
Hello, ma'am. Thank you so much, ma'am. We'll also have some questions from YouTube and Zoom participants. Can I read out for you?
Yeah.
The first question will be, can you again differentiate difference between CSCR and CME?
Yes. You want me to tell again?
Like Punitha can answer, I guess. Central serous retinopathy and CME. Your slides have answers, Punitha. Can you share and explain once again?
Yes, ma'am. Just a minute, ma'am. So if we look for CSCR, it is just a spontaneous serous detachment of the neurosensory retina that can be seen in the macular region with or without the RPE detachment. While CME. So this is also a collection of fluid, but between the outer plexiform and the inner nuclear layer of the retina, which centered around the foveolar, and this will show the loss of foveal depression.
Thank you, Punitha. Ma'am, the next question will be how to differentiate retinal hemorrhages and subretinal hemorrhages.
Yeah, I think I explained that. Retinal hemorrhages, subretinal, you have to look for that EL and RPE. When the hemorrhage, that is, those are hyperreflective thing. When you see a hyperreflective deposits or echoes at the EL and RPE layer, between EL and RPE layer, we call it as subretinal hemorrhage. Above that, we call it as intraretinal hemorrhage. When, as I said, when you heme is present below the PVD line, which she showed on that, we call it as subhyaloid heme.
Thank you so much, ma'am. The next question is, will breaks and hole develop into a retinal detachment?
Yes, the vitreous will pass through the hole and it will, due to its tendency, it will push the retina and it will cause retinal detachment.
Thank you so much, ma'am. The next question will be, differentiate between retinal detachment and retinal dialysis.
Retinal dialysis, it is a circumferential retinal break at the ora serrata, and this may lead to retinal detachment.
Thank you, ma'am. From the YouTube, we have two questions. The first one will be, do all the pigments in retina occur only because of RPE or any other layer is responsible?
Mostly it is RPE only, it is pigmented. So we will expect mostly in RPE levels only, pigmented lesions.
Thank you, ma'am. Next, how to differentiate between different atrophies?
Different atrophies based on their presentations and conditions.
Yeah.
That's it.
Thank you. Thank you so much, ma'am. Anshi ma'am, do you have questions for our moderator?
No, I don't have any questions. I think it was very well taken. Punitha, I'm very happy with the presentation. It was very well and beautifully explained. I think even Mahalakshmi will agree that we tried to cover up all the signs. So basically, the main agenda of this entire optometry series of today was to explain on how the retina is telling us how each sign can let us know what could be the possible disease and for us to understand which layer is responsible. So it's like a connect from what we learn in the first year anatomy and the second and third year about ocular diseases. And finally, we learn about imaging. So Mahalakshmi really brought in that concept of about how OCT can also play a major role as a diagnosing technique. So thank you so much, Punitha, Meenakshi, Mahalakshmi, for such a wonderful presentation. So over to you, Gomati.
Thank you so much, Anshi ma'am. Thank you so much, Meenakshi. Thank you so much for today's moderator, Mahalakshmi ma'am. Punitha, great job, dear. Thank you all so much for your continuous support towards Optometry series. If you like this video, give a thumbs up and share with your friends. To know more about the happenings at Dr. Agarwal's Institute of Optometry, follow our Instagram and Facebook page. Admission is open for bachelor's, master's, fellowship, and internship in optometry. Do apply. The number is given in the description box. Thank you so much, all of you. We'll meet you in the next episode. Thank you, Mahalakshmi ma'am.
Thank you.